So, physiologic jaundice is very common finding in newborn in first week or first 2 weeks of life. Approx 70 to 80% newborns develop jaundice in first week of life. Okay. Few percentage of babies develop severe jaundice, and after that results in irreversible neurodisability or maybe death, that is Kernicterus. Okay. If not managed timely or appropriately. So basically Kernicterus is preventable. Okay. Now for that all newborn babies to be screened twice a day in proper sunlight. Okay. So this is the metabolism of bilirubin. Now breakdown of hemoglobin or other heme proteins. Okay. Heme spelling mistake, heme proteins. Now this comes from destruction of red blood cells, that is ineffective erythropoiesis, okay, or any other causes of hemolytic anemia. Hemolytic anemia, G6PD deficiency or spherocytosis or autoimmune hemolytic anemia, any causes of hemolytic anemia that leads to breakdown of RBC. So hemoglobin and heme proteins. Other heme proteins, that is like cytochrome or catalase proteins. Okay. After that, from heme is converted to biliverdin first. Okay. Heme oxygenase enzyme converts heme to biliverdin and carbon monoxide. Then biliverdin is converted to bilirubin. Okay. And this bilirubin is actually bound to albumin. When bilirubin is bound to albumin, then that is good for newborn, because bilirubin in this condition when bound to albumin cannot cross blood-brain barrier. So bilirubin when will be detached from albumin, that then it will cross blood-brain barrier. And what are the conditions that leads to this dissociation? Hypoxia, metabolic acidosis, okay, any sepsis infection, drugs like ceftriaxone. Okay. Now this bilirubin transported to liver for conjugation, and the enzyme helps in conjugation, that is UDP glucuronosyl transferase. Okay. And this condition, this enzyme, when it is absent, it leads to Crigler-Najjar syndrome, and mutation of this enzyme leads to Gilbert syndrome. Okay. In preterm babies, Crigler-Najjar syndrome, Gilbert syndrome, conjugation will be less. So amount of unconjugated bilirubin will be more. So physiologic jaundice or hyperbilirubinemia will be more. Okay. Now this conjugated bilirubin ultimately excreted in bile, and from there to GI tract and then released in stool. That is stercobilinogen. Okay. Now in this pathway there is one enzyme, that is beta glucuronidase. What does it cause? It deconjugates the conjugate bilirubin. So bilirubin again become unconjugated and transported to liver. So if beta glucuronidase enzyme will be more, then unconjugated bilirubin will be more, because deconjugation process is going on. Okay. Now in preterm, in breast milk jaundice, bowel obstruction, this enterohepatic circulation will be increased. So level of unconjugated bilirubin will be more. Okay. Now difference between physiologic jaundice and pathologic jaundice. Physiologic jaundice appears after 24 hours from day 2 of life, and pathologic jaundice, it appears on day 1. If a newborn having jaundice on day 1, then it is pathological. Okay. In physiologic jaundice, total bilirubin rises by less than 5 milligram per deciliter per day, and in pathologic jaundice it will be more than 5 milligram per deciliter. Serum bilirubin level will be less than 15 milligram per deciliter in physiologic jaundice and more than 15 in pathologic jaundice. Okay. And physiologic jaundice clinically not detectable after 14 days, that is 2 weeks in term and 3 weeks in preterm. Okay. But pathologic jaundice can persist after that time period, and physiologic jaundice resolves without treatment. In some cases it needs phototherapy, but pathologic jaundice we have to rule out the cause, the pathology behind this jaundice, and to be treated accordingly. Okay. Now, causes of physiologic jaundice: decreased RBC survival. Normal RBC lifespan 120 days, here it is 90 days or less than 90 days. And physiological polycythemia, RBC blood count in newborn is more, so that is polycythemia. And poor hepatic uptake and conjugation due to deficiency of cytoplasmic ligandin. Ligandin is the Y protein that helps to transport the unconjugated bilirubin to liver for conjugation. So, if ligandin will be less, then conjugation will be less, so unconjugated bilirubin will be more. And UDP glucuronosyl transferase enzyme. Okay. In premature and preterm babies, these enzymes are less quantitatively. And increased enterohepatic circulation. In breastfeeding failure jaundice or overactivity of beta glucuronidase enzyme, okay, or paucity of bacterial flora in gut, enterohepatic circulation will be increased, so bilirubin, conjugated bilirubin will again become unconjugated. Okay. So physiologic jaundice will be more. Causes of pathological jaundice: some pathology will be there, like maybe ABO or RH incompatibility, okay, RBC membrane defect, spherocytosis, elliptocytosis, G6PD deficiency anemia, all are causes of hemolytic anemia. Okay. Hemoglobinopathies, thalassemia, sepsis, drugs like vitamin K, oxytocin. Okay. Other causes of pathological jaundice, that is non-hemolytic causes: breast milk jaundice, Crigler-Najjar syndrome types 1 and 2 due to deficiency of the enzyme UDP glucuronosyl transferase, and Gilbert syndrome due to mutation of that enzyme, infant of diabetic mother, IDM, and hypothyroidism. Okay. All these are causes of pathological jaundice. Now, what history to be taken? If there is family history of jaundice, anemia or splenectomy, so there will be chances of hemolytic anemia, hereditary hemolytic anemia. If there is any history of liver disease in the family, so we should think of cystic fibrosis or Crigler-Najjar or tyrosinemia. Or sibling history. Sibling history, if sibling also suffered from pathological jaundice or physiological jaundice, then sibling history is important. In breast milk jaundice, blood group incompatibility. From pregnancy, antenatal history, what should we ask? Any illness during pregnancy. Why it is important? Any illness during pregnancy? Illness during pregnancy, why this history is important for evaluation of neonatal jaundice or neonatal hyperbilirubinemia? Because any history of fever with rash in second trimester or basically this is torch infection. Okay. So in torch infection, bilirubin will be more, conjugated hyperbilirubinemia. Then infants of diabetic mothers or any history of maternal drugs taken. Now natal history, any history of birth trauma, vacuum extraction, infants with HIE, hypoxic ischemic insult, delayed cord clamping. Then infant history, if there is any history of poor feeding, vomiting, because poor feeding, vomiting may be the symptom of sepsis. Sepsis also in pyloric stenosis. Okay, delayed or infrequent stooling, stool pass, that is maybe there some intestinal obstruction. Excessive sleepiness, temperature instability or shrill cry, all are features of encephalopathy, acute bilirubin encephalopathy. Okay. Now physical examination. Kramer's rules or Kramer dermal Jones, পরীক্ষায় কিন্তু অনেকেই বলতে পারেনি। So jaundice appears first in forehead and progresses cephalocaudally, okay, from forehead to palm and sole. Zone 1 is forehead and face, zone 2 chest and upper abdomen, 3 lower abdomen and thigh, 4 arm, forearm and leg, and 5 palm and sole. So if there is yellowish discoloration in zone 1, then the bilirubin level will be 4 to 6 milligram per deciliter. Okay. What is the significance of this Kramer dermal Jones? কিছু অসুবিধা? ওটা অ্যাকচুয়ালি দুটো আছে, ওটা লেমন ইয়েলো কালার আছে, ডিপ ইয়েলো কালার আছে। এখানে যেটা দেওয়া আছে এটা লেমন ইয়েলো কালারে দেওয়া আছে, ঠিক আছে। ডিপ ইয়েলো কালারটা 2 to 3 মোর আছে, ঠিক আছে। জোন ওয়ালে যদি লাইট ইয়েলো থাকে 4 to 6, যদি ডিপ ইয়েলো থাকে তাহলে যেটা বলছি 7 to 9, ঠিক আছে। প্রত্যেকটা জোনেই দুটো করে ডিফারেন্স আছে। জোন 2 6 to 8, 3 8 to 12, 4 12 to 14 and zone 5 15 milligram per deciliter. এটাই যদি ডিপ ইয়েলো হয় জোন 5 more than 17 to 18, 2 to 3 difference. Okay. Bilirubin estimation. How to estimate bilirubin? One is transcutaneous bilirubinometer. Okay, this is non-invasive method. And AP means American Academy of Pediatrics recommends transcutaneous bilirubin screening in infants more than 35 weeks, and it is not recommended at total bilirubin more than 15 milligram per deciliter during or after phototherapy or sunlight exposure. Once if you have initiated the phototherapy, then transcutaneous bilirubinometer we should not use, and when the level of jaundice is more than 15, then also we should not use this. In this case we will estimate by bilimeter, that is a type of spectrophotometer, or Diageo's method for total and conjugated bilirubin estimation. Then we get unconjugated bilirubin from total minus conjugated bilirubin, and measurement of EtCO2 breath level, carboxyhemoglobin. Okay, earlier I said that heme converted to biliverdin and carbon monoxide. Okay, and the level of equimolar biliverdin and carbon monoxide we get. So if we estimate the value of carbon monoxide, then we will get the value of bilirubin. Okay. Both are same. Now additional lab test, mainly for the evaluation of pathological jaundice. Okay. Mother's blood group RH and antibody screen. Same infant blood type RH and direct antiglobulin test, DCT or DAT. Okay. For ABO and RH incompatibility. Peripheral smear and retic count for Coombs negative hemolytic disease, hematocrit and hemoglobin for polycythemia, direct or conjugated bilirubin for cholestasis when the jaundice more than 2 weeks. Okay, jaundice persisting for more than 2 weeks, then we have to rule out cholestasis. G6PD measurement if total serum bilirubin is more than 18 milligram per deciliter. Other causes like sepsis, metabolic defect, hypothyroidism. Okay, so specific investigation for specific causes. Congenital infection, that is torch infection, okay, torch screen, metabolic for metabolic defect, metabolic screening, for sepsis, sepsis screening, for thyroid, T4, TSH. Now management of hyperbilirubinemia. Main management of hyperbilirubinemia is phototherapy. Okay, maybe single surface, maybe double surface phototherapy. What is the aim? To prevent severe hyperbilirubinemia and subsequent neurological damage, that is Kernicterus. Okay, this is the Bhutani nomogram. Okay, from this nomogram we decide whether the baby needs phototherapy or not. Okay. This is for newborns born at 36 weeks gestation or more than 36 weeks. This is with phototherapy with no neurotoxic risk factor present. Just know the name Bhutani nomogram. This is the Bhutani nomogram with when one or more neurotoxic risk factors are present. I will discuss later what are the neurotoxic risk factors. Neurotoxic risk factors, what are they? Gestational age less than 38 weeks. Okay. Isoimmune hemolytic disease, G6PD deficiency, albumin less than 3 gram per deciliter, sepsis, and significant instability in the previous 24 hours. Okay. The patient is hemodynamically unstable. Okay. So this is the neurotoxic risk factor. If one or more neurotoxic risk factor present, then we have to decide which Bhutani nomogram chart to be used. There are separate charts. Okay, phototherapy, intensive phototherapy should typically produce decline in total serum bilirubin of 1 to 2 milligram per deciliter within 4 to 6 hours. It is useful when we will check where we are giving phototherapy, but when the phototherapy is adequate or not. Phototherapy is actually working or not. For that, we have to check. Characteristic of device, phototherapy device is the wavelength is important. Okay, 460 to 490 nanometer, and 460 nanometer is the wavelength where bilirubin most strongly absorbs light. And what are the mechanisms? 3 mechanisms. One is structural isomerization, when bilirubin is converted to lumirubin, that is water soluble, so it excretes into bile and urine. Second is photoisomerization of 4Z15Z isomer to 4Z15E form, that is again excreted in bile, but it is reversible. Okay. So when we will withdraw phototherapy, again the isomer will change, and next photooxidation. Photooxidation converts bilirubin into small polar products. So this is water soluble, excreted in urine. Phototherapy administration. During phototherapy administration, an opaque mask should be applied for covering the eye. We should cover eyes and genitalia. Okay. Another thing is fiber optic blankets or Billy blankets. That is just like phototherapy, that is like blanket. We should keep this blanket beneath the baby. Okay. And during phototherapy, exclusive breastfeeding to be continued, but short interruptions for feeds we have to look after. Okay, we'll continue breastfeeding, but up to 30 minutes time we will allow for breastfeeding. Adverse effects of phototherapy: transient passage of loose stools, hyperthermia, okay, irritability, dehydration due to insensible water loss, bronch baby syndrome in infants with direct hyperbilirubinemia. Okay, why? Due to impaired excretion of photoproducts of bile pigment, and late complications like damage to DNA, skin malignancy, okay, patent ductus arteriosus, gonadal damage, retinal damage. That's why for gonadal damage and retinal damage, we cover eyes and genitalia. And if we give phototherapy under supervision, okay, so chances of these side effects are very less. It is a very safe procedure. Now, exchange transfusion. When the level of bilirubin is very high, that phototherapy, only phototherapy is not useful. Then exchange transfusion we have to do to remove bilirubin and to prevent the neurological damages. Now, exchange transfusion is most effective method for rapid removal of bilirubin. Phototherapy is useful, but in exchange transfusion, we remove the bilirubin very rapidly. It also removes antibodies and sensitized RBCs. Now, American Academy of Pediatrics recommends that serum bilirubin cutoff for exchange transfusion in a healthy term baby to be 25 milligram per deciliter. Okay. So, it is a rough calculation. If palm and sole are stained, so bilirubin level will be more than 25 milligram per deciliter. Okay. Deeply stained, then we have to prepare for exchange transfusion. Now, bilirubin albumin ratio to be considered, because according to level of albumin, bilirubin level will change because bilirubin binds to albumin. Exchange transfusion performed through umbilical venous catheter using push-pull technique. Okay. The type of blood we will use is very important. That is type O. Type O irradiated PRBC suspended in AB plasma and cross-matched against maternal plasma and cells. So, when we will prepare for exchange transfusion, we have to send both mothers and infants' blood to the blood bank. We need both. Not important. Only complications of exchange transfusion: thrombocytopenia, coagulation abnormalities, hypoglycemia, hypocalcemia, hyperkalemia, and acid-base abnormalities. So, where phototherapy is very safe procedure, but exchange transfusion has some serious complications. So, we have to monitor the baby for next at least 6 to 12 hours. We have to check calcium level, blood sugar level. Okay. This is again Bhutani nomogram for exchange transfusion. One with no neurotoxic risk factors, and another is when one or more neurotoxic risk factors are present. Now, pharmacologic therapy, some drugs have role in reducing the level of bilirubin, okay, but that is not much significant, like phenobarbital. Phenobarbital 5 mg per kilogram per day for 3 days. We occasionally use this drug. Another is clofibrate, but main treatment is phototherapy and exchange transfusion. Risk factor for neurotoxicity: one is acidosis, low albumin level, disruption of blood-brain barrier in sepsis, asphyxia, intracranial hemorrhage. If there is Coombs positive, DCT positive, direct Coombs test. Bilirubin displacers, free fatty acid subtraction displaces bilirubin from albumin, okay, causes neurological damage because that bilirubin crosses the blood-brain barrier. Encephalopathy and extreme preterm. Now, acute bilirubin encephalopathy. It is the manifestation of bilirubin toxicity. Now, there is score, that is bilirubin induced neurological dysfunction score. Okay. So, just know that 1 to 3 is mild, 4 to 6 is moderate, and more than 7 is severe. Acute bilirubin encephalopathy. Okay. Now, there are stages like mental status, 0 for normal, 1 for sleepy or poor feeding, 2 for lethargic, irritable, any jitteriness, and 3 if there is unable to feeding, any apnea, seizures, coma. We have to check muscle tone. Normal 0, hypertonia with hypotonia 1, neck stiffness, flexor spasm, hypertonia 2, and retrocolis, opisthotonia, severe hypotonia with limb is 3. Cry pattern normal 0, high pitch cry 0.1, shrill cry if intermittent then 2, weak or absent cry 3. We have to calculate the total score and accordingly grading will be done. The acute bilirubin encephalopathy is mild, moderate or severe. Kernicterus is the chronic and permanent sequelae of bilirubin toxicity that develops during the first year of age. Newborn baby may develop signs or symptoms of acute bilirubin encephalopathy, or it's possible that the neonate may not have the signs and symptoms at early phase, but later the baby will develop kernicterus. And if the newborn develop kernicterus, then there will be chorioathetosis with involuntary muscle spasm, chorioathetoid cerebral palsy. Okay. Now, signs of kernicterus: chorioathetoid cerebral palsy with neuromotor impairment, sensory neural hearing loss, limitation of upward gaze. Upward gaze will be limited. Dental enamel dysplasia. Okay. These are the signs of kernicterus. Conjugated hyperbilirubinemia. Mainly in neonatal hyperbilirubinemia, that is unconjugated hyperbilirubinemia. Okay. Now, conjugated hyperbilirubinemia, if we get, then that is pathological and we have to rule out the cause. So, what are the causes? Idiopathic neonatal hepatitis, torch infection or any other infection, that is sepsis, any malformation, biliary atresia, bile duct stenosis, choledochal cyst, Ala-Gili syndrome, sorry for spelling mistake, congenital hepatic fibrosis, and if there is metabolic disorder, galactosemia, tyrosinemia, cystic fibrosis, if the baby is getting total parenteral nutrition TPN and congenital hypertrophic pyloric stenosis, in all these cases the hyperbilirubinemia will be conjugated. Okay, that means level of direct bilirubin will be more. Now, diagnosis: if there is, we get acholic stool, pale color stool, okay, suggest obstruction. Biliary atresia, okay, biliary atresia will get clay colored or pale colored stools. Now, then next is liver function test. Liver function test, after that abdominal USG, ultrasonography for biliary atresia, choledochal duct cyst, vascular malformation. So, first we will do LFT, then USG, ultrasonography. So, one by one we will rule out the causes. And hepatobiliary scintigraphy to differentiate biliary atresia from other causes of cholestasis, that is idiopathic neonatal hepatitis, and percutaneous liver biopsy. It is the definitive procedure. Okay. Management: the baby with cholestasis or cholestatic jaundice, how to manage? Will give low fat and high protein diet supplemented with MCT oil, medium chain triglyceride, and the level of vitamin A, D, E, K we have to give the 5 times the RDA, recommended dietary allowance. Phenobarbital has shown some therapeutic benefit to some extent. Exclusion of lactose and sucrose from diet in patients with galactosemia. Infants receiving TPN, minimal enteral feeding to be initiated as soon as possible for gut priming. Okay. Now, Kasai's procedure in biliary atresia, and it is to be done before 2 months of age. So, biliary atresia diagnosis is very important before 2 months, or to be specific 8 weeks, 8 weeks of age. And if there is end stage liver disease, then no other choice, only liver transplant will help. শেষ। বল নিওনাটাল জন্ডিস এবার কে কি বুঝলি একটু বল। নিওনাটাল জন্ডিস সেরকম কেউ কিছু বলতে পারেনি। জন্ডিস প্রথম কোথায় দেখবি বল, তোকেই বলছি। জন্ডিস কিভাবে দেখবি আবার? হ্যাঁ, এই পড়ানোর পরে হ্যাঁ স্ক্লেরা। নিওনাটাল জন্ডিস নিওনেটে কোথায় দেখবি বল? হ্যাঁ, কোথায় দেখবি বল প্রথম? ফোরহেড, তারপরে মানে লাইকলি মোর দ্যান মোটামুটি 20-র উপরে হবে, ঠিক আছে? তারপরে আচ্ছা নেকে দেখবো না? দেখবো না, দেখবো না। দেখবো, ঠিক আছে, কিন্তু যখনই কোনো জায়গায় আমরা প্রেস করব তখন বনি প্রমিনেন্সের এগেনস্টে হলে আমরা বেটার দেখতে পাই, ঠিক আছে? সেই জন্য ফোরহেডের পরে চেস্টই আমরা দেখবো। নেকে তো বনি প্রমিনেন্স নেই, ওই জন্য নাই। থাকবে জন্ডিস নেকেও থাকবে, কারণ উপর থেকে নিচেই আসবে। আচ্ছা বল, কাকে ফটোথেরাপি দেবো আর কাকে এক্সচেঞ্জ ট্রান্সফিউশন করব? প্যাথোলজিক্যাল যদি হয় তাহলে কি করব? প্যাথোলজিক্যাল যদি হয় তাহলে ফটোথেরাপি দেবো, দেখ হ্যাঁ। ফিজিওলজিক্যালে ফটোথেরাপি দেবো, আর প্যাথোলজিক্যালে? ফিজিওলজিক্যালে কখনো এক্সচেঞ্জ ট্রান্সফিউশন করব, আর প্যাথোলজিক্যালে শুধু এক্সচেঞ্জ দেবো না এক্সচেঞ্জ ফটোথেরাপি দুটোই দেবো? দুটোই দেবো। আচ্ছা কি করে ডিসাইড করব কখন এক্সচেঞ্জ করব? বড় বড় যে চার্টগুলো ছিল না, ওই চার্টে আমরা প্লট করব। নিচে জেস্টেশনাল উইক আছে, এজ অফ দ্য বেবি, হ্যাঁ, ওখানে জন্ডিস আছে, চার্ট আছে। যদি ডেঞ্জার জোনে পড়ছে তাহলে তোমাকে দিতে হবে এক্সচেঞ্জ ট্রান্সফিউশন। যদি সেফ জোনে আছে, সেফ জোনে, তাহলে তোমার ফটোথেরাপি চলবে, কিছু করতে হবে না। ফটোথেরাপির জন্য আলাদা আছে চার্ট, এক্সচেঞ্জ ট্রান্সফিউশনের জন্য আলাদা আছে।